So I would be annoyed either way that my son is keeping somebody's daughter as his wife, and I'd be grossly annoyed that my daughter is being kept somewhere by somebody's son as a wife. Let's follow the right channels, So are we surprised that, the issue of sexually transmitted infections is quite high in this country? It's obvious that these are some of the reasons. When you talk about contraception, sometimes you use the term contraception interchangeably with family planning. When you talk about family planning, is that you have a family, you had one child, 2 babies, 3 babies, or whatever number it is, and you want to have more, but not straight away. So you want to space them. Contraception is basically you don't want to get pregnant. Just as the word suggests, it's contraception. So you don't want to get pregnant. And it gets even more interesting. And this young Martin has a right to come to number 14 Crossbar Street and knock on the door on Mr. John Martin and Mr. John Smith and say, "Excuse me, good morning. My name is Martin Jr. And I was told that my father, Edwin Martin, had a problem and they used your sperm and I'm the one," that sort of thing.
Hello, good people. Susie Ledadem, living positively regardless.
Hello, guys. Good afternoon, or is it good morning, wherever you are. My name is Dr. Kireki. I am a consultant obstetrician and gynecologist. I am a fertility specialist. I teach at the University of Nairobi, Department of Obstetrics and Gynecology. I'm a senior lecturer in that department. And also, I'm the president of the Kenyan Obstetrical and Gynecological Society. Thank you very much. Okay. So we talk about infertility, we talk about fibroids, we talk about endometriosis. We have the highest fertility rates, which is about 4.1 babies per every woman. That is statistically. You can never have a 0.1 baby or half a baby. But that's just statistics.
Yeah.
And then we also have the highest infertility rates. For example, some studies which were done some time ago put the infertility rate at about between 15 and 20% of the Kenyan population has an issue with either primary, what we call primary, or even secondary infertility.
And before we wrap up, maybe there are 2 things I would want to understand.
Yes.
I'm picking it from, I wanted to ask you a question, but I feel like you've answered, but I still want to pose in case there's something to it. Because I wanted to understand whether there is a case that is so final, like with this one, we say, yes, there is technology, we can try everything, but with this one, don't even bother. I've already picked issue about the age, that at some point in age, you are devising them, just relax, accept the fate. And also now, about the social kind of life, if you're taking hard drugs, unless you are ready to leave them, we may say there is no hope over this. Yes. Are there situations where you feel like this one, Madam or sir, kindly relax. You may never be able to have a chance to be a dad or a mom.
First of all, as we said right from the beginning, God has made it possible for us to have this knowledge. And this knowledge is for us to help his children, as it were. I have not got to a place whereby I say, you know what, forget about this, it's not going to work. There are options. And there are many options. Say, for example, the lady who has blocked tubes, we have an option of doing IVF, collecting eggs and getting sperm from the husband, creating embryos and, transferring them. The man who did a vasectomy, for example, we can be able to get sperm from from elsewhere, what you call surgical sperm retrieval, and we'll create embryos and we'll transfer. I think the cases you're asking is, for example, whereby, let's say, a woman, for whatever reason, medical reasons, surgical reasons, or even general health reasons, for example, the womb is very distorted by fibroids such that it cannot be able to carry a baby by itself. So this woman cannot be able to carry a baby. Or maybe she's had some serious surgery, for example, brain surgery or even heart surgery, or even she's had, I don't know, she's had some serious, let's say, what you call clots, DVT, and so on. Even in these very difficult medical surgical cases, there is always a way out.
Okay.
So there is no such a case where I can say, you know what, forget about it, you can't be a father, or, you know, whatever it is. Because, for example, if this woman does not have a womb, for example, we have cases like that, where naturally she was born that way, there is a possibility of doing this through surrogacy. So somebody else can carry a baby for her. The one who has had major surgery, brain surgery, or heart surgery, whereby we know that if she were to get pregnant, the strain on her body would be too much, it may lead to other consequences, then we suggest somebody else can carry a baby for her. Where age is a factor, and this woman wants still to have a baby, we say, look, if we try using your own eggs, most probably we may either not get an eggs, or we get very few eggs, and the quality is going to be very poor, and then this has a knock-on effect on the on whether you're going to have a baby later on. So there is an option of using donor eggs, for example. So somebody younger can donate her eggs, and we can use her husband's sperm, for example, and then she can carry the baby herself. Or if she cannot carry the baby herself, then she can use a surrogate. So the same with a man, for example, whereby if he does not produce sperm, but still wants to have a baby, we can use what you call donor sperm, and we use his wife's eggs, for example, and the wife can carry, or somebody else can carry for them. So it just depends on where we are and what the clinical situation is, and whether the couple themselves are okay with the options. The issue sometimes comes with the options that are available on the table. We say, okay, in this case, using your eggs, it's not a very good idea. It's a very expensive, sort of investment. And if you're going to invest so much and you end up getting one egg which is poor quality, that is a poor investment. Why don't you consider somebody else getting eggs for you? And then they say, no, me, I want my own eggs. Fine. Let's go ahead. But there are options. So I've never reached a place whereby I say, forget about it. No, the options are there. It's just a question of whether these options are palatable to the couple or not. That's a different thing altogether.
A beam of hope there. So don't give up whatever situation it is. Wow. Now, Dr. You've mentioned about surrogacy. Maybe just in passing, are you able to maybe let us understand maybe the implication, legal and also medical implication of surrogacy?
As I just mentioned, that sometimes these women may not be able to carry a baby because of health reasons. I had a patient who had miscarried 12 times. 12 times. And the only option for her was, look for a surrogate. There are others who have tried and it has failed. Others have problems with their with huge fibroids in the womb. Others have had major surgery, whether it is, brain surgery or heart surgery and so on. So these ones, we normally just suggest to them that they consider somebody else to carry a baby for them. And it is legal. So, for example, you carry a baby for a client. Actually, they are called intended parents. So the intended parents already have an embryo or embryos. So once you've agreed with them that you're going to carry this baby, we prepare you. And one of the conditions for one to be a surrogate is that you must have had a baby or babies. You can't just come at No. You must have had a baby or babies because of that connection that you're going to have. It's an emotional connection. And we don't want you to get emotionally connected to this baby who does not belong to you. So you have your baby or babies, all right? But we counsel you, we tell you, carrying a pregnancy is not like going to the market and carrying, buying 5 kilos of sugar and bringing it home and whatever. No, there is that, it's 9-10 months of carrying this baby. And you are the one who is nurturing this baby. It is your blood that is, giving this baby nourishment. When the baby starts kicking, it's you it's kicking. You know how it is to carry a pregnancy. And then you are the one who's going to deliver. So whether you like it or not, you are going to be emotionally attached. So we don't want that attachment for a lady to get attached to a baby the first time, and that baby is not hers, sorry. So number one, you have to be, must have had a baby or babies. Number two, you have to be healthy, because you don't want you to have health issues while carrying somebody else's baby. So there's a screening test we do. We make sure that you're healthy, you are HIV negative, hepatitis negative, you don't have syphilis, and generally that you are okay. Now, once we've done this and you agree, then, of course, we start the process of preparing you. We have these embryos frozen somewhere. And once you are ready, we take these embryos, we thaw them, and then we transfer them to you as a surrogate mother. After 2 weeks, we do a blood test to make sure whether the pregnancy has implanted or not. And once that it has implanted, then you start, the normal antenatal care where we take care of this pregnancy and so on. There is a stipend that you get as a surrogate, to take care of your accommodation and your food and so on, while the intended couple or the intended parents take care of all the other costs, hospital costs, blood tests, scans, etc., when you're having your antenatal care. When it comes to delivery, of course, they take care of the delivery costs and hospital costs as well. Now, as soon as you deliver this baby, the baby is given to the intended couple, and they start bonding with that baby. And then now, what normally happens is that when you leave hospital, there is what you call the birth notification. The birth notification is in the name of the mother, who is you, because according to the Kenyan law, the mother is the person who has delivered this baby. So, for example, if the husband of this couple is called Caleb, so the husband's name is going to be Caleb, and the mother's name is you, Susan, who is the surrogate. Now, it is a problem, obligation, and responsibility of the intended couple now to take this birth notification, go to a family lawyer who will start now a court process to put the name, get a court order where the name now of the real mother, let's call her Mary, have Mary's name put on the birth certificate of the baby. So that takes a bit of time, but there are lawyers who can do that. And then at the end of this delivery, you as a surrogate, you are paid a lump sum, for doing this. Of course, it really is not a payment, because how do you pay? You really can't pay for this process, but it's a token of appreciation, really, because you can't pay for those emotional connections. You can't pay for those sleepless nights. You can't pay for the vomiting and, feeling horrible. And especially towards the end when the baby is everywhere, kicking you everywhere. You can't really pay for that per se, because you cannot put a price on. So it's just a token of appreciation for helping, because it's really helping, for helping this couple who naturally may have had issues or may have had issues in getting pregnant. Okay.
The parent who are offering the embryos, are they covered legally in that the intended parent may decide, we have changed our mind, the baby in here is my child, I'm not giving them out?
Well, we encourage them, they must have a contract. They must sign a contract, and this contract is binding between the surrogate and the intended parent. And I tell them this is basically to protect you against each other. So it protects the surrogate against the intended couple, intended parents, and the intended parents against the surrogate. So the surrogate can decide, now this is my baby. Okay, if it's your baby, you have to prove it is your baby. Do a genetic test. and then prove it's your baby. That sort of thing. But thank God I've not been in such a situation before. And I've done this and I'm still doing it. Like now, I think I have 3 or 4 surrogate mothers I'm preparing.
Okay.
Yeah.
Can we register with you if we want to be surrogate mother?
Well, you can. You can. Ona huyu mwanabiashara.
I'm already imagining the appreciation, not the payment, the appreciation.
No, like Kenyans, you always look at the end of it. You don't want to see the trouble that you go through.
No, it's the appreciation bit of it.
At the end of it, yeah.
No.
But you see, the other thing is that it's not that we have, these intended parents. There are so many of them because it is a process, and sometimes from time to time we get them, and then we actually look for these surrogates. So if we get ladies who are willing, why not? We will, welcome them.
Age limit
and then
to
wait.
be a surrogate mom?
Sorry?
Age limit to be a surrogate mom?
That is an interesting question, because in some countries, for example, in the UK where I was working, they sort of don't really have a cutoff. They say, though they tend to say, less than 40, less than 40 something years. What I do, my practice here, I try to put the age limit at around 35. Simply because the older the ladies are, or the maturer the ladies are, the higher the chances of having other complications, obstetric complications, for example, what we call gestational diabetes, hypertension, what we call preeclampsia, and so on. So when you're carrying somebody else's baby, obviously we don't want these complications because they are going to directly affect the baby. So I try to have that cutoff lower than 35.
Sisi watu wa 40 years, tafadhali inua mkono.
Ati umefika 40.
Tuende ile tent ya. Tuende tent ya blue, we think of something different to do with our own lives. Well, Doctor, you know that you've compared Kenya with other places.
Yes.
Are there situations that you think can be resolved away from the country more easier than here in Kenya when it comes to infertility?
Actually, I don't think so.
Okay.
I don't think so. For example, if you have cases, like I said, I was practicing in the UK, the cases of, let's say, gamete donation, where there's donation of sperm or donation of eggs and so on. It's more complicated out there in the UK, for example, than in other countries. So we'd get patients who come who are UK citizens, but they would go to Greece, they would go to Ukraine, they would go to, into other places to go and have gamete donation, whether it was egg donation or sperm donation, and then they would do the IVF there and then come back to the UK pregnant. Simply because the UK has a law which says that if you are going to have gamete donation, let's say a man has a challenge and he uses sperm from a donor. Now, let's call this donor, he's called John Smith. Okay? And you, let's say your name is what? Edwin Martin, whatever it is. So Edwin Martin has a problem and he uses John Smith's sperm. So once Mrs. Edwin Martin becomes pregnant and she carries this baby to term and delivers it, you are obliged by law that this baby, small Martin, by the time he or she gets to adulthood at 18, you will have to declare, you have to tell him or her that Daddy had a challenge and they used sperm from Mr. John Martin. Mr. John Martin lives on, let's say, 14 Crossbar Street in London.
Tricky.
So, and it gets even more interesting. And this young Martin has a right to come to number 14 Crossbar Street and knock on the door on Mr. John Martin and Mr. John Smith and say, "Excuse me, good morning. My name is Martin Jr. And I was told that my father, Edwin Martin, had a problem and they used your sperm and I'm the one that sort of thing. That sort of thing. Now, you see, that thing actually, when they passed that law, it reduced drastically the number of donors, gamete donors, sperm donors, and egg donors, because they must have a register.
Okay.
Where they have every clinic which does that has a register, so they know and they can track whose sperm was used on who, and so on.
Okay.
So that was a big deterrent. That is why most of the UK cities, the ones who could afford it, would go elsewhere. So they don't have any obligation of telling this baby anything, okay? Because they went and got pregnant outside there, came and delivered the baby in the UK. Nobody's the wiser, and maisha yanaendelea. Imagine something like that being done in Kenya.
Kwisha.
Kwisha. And God forbid that you are a youngish man and when you're in university, umesota, you don't have anything, and you did this one, and then God forbid you are prime cabinet secretary, or you're the president, or you are a minister, or you're somebody important somewhere. And then this young man comes and says, I was told, you are my really? It will be a huge problem. It will be a huge problem. So some of these things actually can be a bit of a challenge. The other thing actually is that we may think we are so-called developing or third world countries. Last week I had a couple who came to see me here from London, and she has fibroids and the husband had challenges and so on. Guess how long they have been waiting to see a gynecologist? 3 years. 3 years to see a gynecologist. 3 years. And when every time they go to see, they see what we call the GP, general physician, they're told, no, you can go and keep on trying. Go and keep on trying to have a baby. Go and keep on trying to have a baby. For 3 years, they've not been able to see a gynecologist. So when they came here, we did all the tests. Within 2 days, we knew what the problem was. But in the UK, it is impossible to do that. I know it because I worked there. I know how the system works. So you have to go to the GP. The GP is the gatekeeper. Wewe Susan, apana, this your case doesn't need to go to see a specialist. Wacha tungangane na wewe tu hapa. Nakuja, I give you medication. Come after 6 months. Let's try and book you to see a gynecologist or whatever it is. No, the list is too long, whatever it is. So time. So in some respects, we are actually better off. Because here you can actually go to your gynecologist, say, no, go and see a specialist, and actually directs you to a specialist straight away. How I wish that we could strengthen this system that we have instead of collapsing it the way it is collapsing left, right, and center. Okay. Because in that, and by the way, it's not only in the UK alone. I've had patients from Canada as well. Say it's the same problem. To see a fertility specialist bothers on the impossible, because there are these gates which you have to jump through. But here you come and say, I'm having a challenge. I've been trying to have a baby and it's happening. So you check, there's a fertility specialist. You go straight away. And, we do all the tests in a day or in a week. We sort of have done all the tests. And if there's a test which is cycle-dependent, we wait for the cycle. Once we've done it, in a month at most, we will know exactly what the problem is and what we are going to. So in that way, we are actually a lot better. But how I wish that we could get more specialists to come in and we strengthen our public health system, which is collapsing, unfortunately.
Unfortunately. I don't want to be a pastor, because in my local church, pastor will say we are adding, this is the last verse, then we keep reading more verses. But in addition,
you can be an assistant pastor, deputy pastor.
In addition to anything else that Dr. would wish to address it to our viewers, I would also want to pose the question. Sometimes, actually, I think nowadays it's very common. Young people in our campus, once you get there, there is a high chance you'll be someone's husband and someone's wife. And definitely because you're in school, you don't want to start a family. You just want to be a wife or to be a husband. And so definitely now there comes in the issue of using family planning. Do you think it has an impact to now later on when people want to get children?
Yes and no. Let me start with the no. Then I'll come to the yes. First of all, once you go to university, if I hear that my daughter is somebody's wife, I think I'll be very annoyed. I did not send her there to be somebody's wife. Neither did I send my son there to be somebody's husband. Because in order for you to be somebody's husband, you must be independent. It's not me paying for your accommodation, not me paying for your sustenance, paying for your school fees, and so on. If you decide to play in the big league, then be ready to shoulder the responsibility. But you don't go there, purporting to be playing in the big league. Kumbe ni bure kabisa, you only get whatever. So I would be annoyed either way that my son is keeping somebody's daughter as his wife, and I'd be grossly annoyed that my daughter is being kept somewhere by somebody's son as a wife. Let's follow the right channels. You want to be somebody's wife? Mulete nyumbani, tumujue. We look at him, we say, okay, you have decided you want to get married. We are happy to give our daughter away to this man. And na tunajua anaenda wapi. So now there in campus, you even don't know who this boy is. You don't know who this guy is, and whatever it is. You don't know whether this boy, this is the only boy that, this is the only lady that he is, having intercourse with. Most probably not. We'll be having several of them, So are we surprised that, the issue of sexually transmitted infections is quite high in this country? It's obvious that these are some of the reasons. When you talk about contraception, sometimes you use the term contraception interchangeably with family planning. When you talk about family planning, is that you have a family, you had one child, 2 babies, 3 babies, or whatever number it is, and you want to have more, but not straight away. So you want to space them in a way that is comfortable for you. So between number 2 and number 3, let's say you want 3 years. So you use something to prevent you from getting pregnant while you are planning to have the next one. Contraception is basically you don't want to get pregnant, just as the word suggests. It's contraception. So you don't want to get pregnant. Now, there are different ways of using contraception, especially hormonal contraception. We use contraception, number 1, if, for example, a woman is having very heavy periods. We use it to actually reduce the amount, and also whatever other symptoms that can sometimes accompany those very heavy periods. For example, pain during menstruation, and so on. So we can do that. We use contraception, for example, if you've got married, and when you look at your wedding and you look at your honeymoon, you are going to have your periods during honeymoon. And obviously, you don't want to have your period during honeymoon. So we can actually push those periods away, such that you are able to enjoy your honeymoon, properly. We also use contraception, hormonal contraception, for example, in the treatment of problems with endometriosis, which is a big problem. Affects about 10, sometimes even up to 15% of the women who are in the reproductive age. Now, we also use contraception for you not to get pregnant. Okay, so we use it. Why? Because the hormonal contraception, when you use it, it affects what you call the HPO axis, hypothalamus, pituitary gland, ovaries. So the ovaries are not working. If the ovaries are not working, then the lining of the womb will not be ready, so there'll be no pregnancy. Okay, and so on. Now, so it is well known and it's documented that actually women who take a hormonal contraception, once they stop and the period, the HPO axis starts working normally, they get pregnant naturally. There are no problems. And sometimes they may even have twins more than when it compared to the normal population. So that is also documented. So to answer the first question, does it affect fertility? No, it does not affect fertility. Now, I'm going to come to the yes that it does affect infertility. And this one, I think I would narrow it down to some of the pills that are used because there are different types of pills when you talk about hormonal contraception. We have what you call combined oral contraceptive pills, where you have two hormones put together so that they sort of mimic the cycle. And then you have what we call a mini pill, where you have only one hormone in the pill. And usually this is for women who have delivered and they want to use the pill. So they use the so-called mini pill. And for women who have contraindications to using estrogen in the tablets. Remember the combined oral where you have two? In the two of them, you have a hormone called estrogen and another one called progesterone. So if there are contraindications, for example, a woman who has diabetes, a woman who's had a clot in the past and so on, they cannot use estrogen, so they use the mini pill, which has progesterone only. Now, there is also another pill, which unfortunately I think it is being misused by our students in the universities. And that is called the emergency pill, the P2. P2 is an emergency contraception. And I want to underline here, emergency. Now, just like in the bus where it's written an emergency door at the back, when it's an emergency door, you use it when there is an emergency. You don't go breaking that so that you can go in before other people get in the bus. So it's the same thing with the P2. You use that. I said, oops, today I had intercourse. Actually, I had not planned to kufanya, but the emotions got better of me. And because normally it doesn't happen, I'll go and buy that P2 and use it. It has a high quantity of hormones, which basically will stop any implantation that's going to be there. But you cannot have an emergency every 2 days, and it's a planned emergency. I'm going to visit my boyfriend, but I'm carrying a P2. I'm carrying a P2 with me. It's a planned emergency. There's nothing like a planned emergency. That is not planned. Now, the problem is that when we use this P2, every 2 days, every weekend, and whatever it is, it seriously interferes with that HPO axis. So all of a sudden, your periods are all over the place, your cycles are very irregular and whatever. So it becomes a huge challenge later on when you now say, now I have stopped the emergencies. Now nataka niwe msichana mzuri, nienda kanisani, nipate kijana nimeokoka. Nimebatizwa kwa jina la Yesu. That becomes a problem. Please, young people, don't use that P2 every weekend or every 2 days or even every day, because there are cases like that. Please don't, because it does interfere with the physiology of the cycle itself, and then later on you can have challenges. That is number one. And then number two, the use of the pill when it came out in 1961, that is when the first combined oral contraceptive pills came out, it became with female liberation. Because before that, it was like, no, you can't have this. Or if you have an affair, or you have intercourse and you're not married, or you become whatever. So now with this came liberation in that I can take the pill and I can have sex with whoever I want, and I'm not going to get pregnant. And then after that, of course, there became issues of sexually transmitted infections and so on. And then they say now, if you take the pill, you are going to be infertile. No, it is not cause effect. It is not the pill which causes infertility, but it is you taking the pill and what you do after you have taken the pill, which can lead to infertility because of the sexually transmitted infections. When you have more than one partner, and this partner, you may have only one partner, but he has several partners out there. So you think he's playing home matches with you, lakini anakuwa na international matches, away matches, anakuja na home matches. So we end up having this problem. So I think that is something important for our viewers to understand.
Any other thing that you'd want to address before we end
I think what I want to say is that, first of all, thank you very much for inviting me to talk about these topics, which I think are very important for the society, and especially for our, I don't want to call them young people, but for the general public. Essentially, infertility is a problem, is a challenge. We accept that it is a challenge, but just like in every challenge, we have solutions, and these solutions are actually here. It doesn't matter. All the solutions that are available out there, whether it is in South Africa, whether it's in Germany, the US, or whatever it is, they are actually available here. We can do anything. We can do actually 99% of what is done there. We can do it locally. What we can't do at the moment is to freeze the ovaries, because sometimes in the cases of women who have ovarian cancer, for example, or who are going for radiation therapy and so on, where we can take a bit of the ovary and freeze it, and then later on implant it to the ovary, and whatever it is, that is the only thing we can't do. Everything else, we can do it here. Everything, and even better. Yeah. So don't think about challenges out there that you will get the best in the UK or whatever it is. Sisi tumeishi UK na tumefanya hii kazi huko na tumeleta hiyo experience hapo. So why do you want to go to the UK? So we are here to help you. The knowledge, God has given us the knowledge, God has availed us the skills, and actually these skills are for us to help you to attain your objective.
Okay. How I got to meet Dr. Kireki the first time, it was through your online platform.
Yes.
And I don't think there's any harm you mentioning maybe where people are able to even access to know more about you.
Yes. Today we're actually meeting in my small office. And my office is located on Ngong Road, a building called Fifth, like 5. Because most of them, when they say Fifth, they say 6th. No, it is Fifth, like 5, Fifth Avenue Office Suites, 3rd floor, suite number or room number 314. Fifth Avenue Offices, Ngong Road, 3rd floor, 314, and the phone number is 0780 170 170. 0780 170 170. I'm usually in the office on Tuesdays and Wednesdays from around 2 o'clock. Tell a friend to tell a friend that actually the issues that we have, issues of infertility, we can actually help solve them here locally. Karibu sana.
Thank you. You guys, you know, in my motherland, the one way to achieve, to see that a couple is achieving after marriage is when you see them start increasing in weight. That's an achievement. You're like, wow, you are taking good care of our daughter. You are taking good care of our son. Today we know it can pose a threat to our health when it comes to fertility issues. Wow. And I think Dr. might take away home, and I really want to amplify that. And I really wish I had the ability to go and ask, when is it happening? Let us push. Is when you mentioned that there is a plan that in Kenyatta National Hospital,
Yes.
the IVF center will be established there.
Yes.
Because I can tell you, we have gone around the private sectors that are offering these, and it is way too high, expensive.
Yeah.
And I'm imagining when it comes to Kenyatta, hopefully
it will be slightly cheaper. Remember, it is expensive because we import everything that we use. We import the medications, we import what we call media, we import the commodities, we import everything. There is nothing that is locally produced. So when you find the cost is high, it's because of that. And God forbid, when the economy is a bit low and the shilling is weak, the cost is going to be high, unfortunately. But we hope that with the time, we will be able to have the cost a little bit lower than where it is.
Is there anything that will come in our age, or do you think it may?
You know, one of our compatriots says our dreams are what? Are valiant.
Valiant.
So let's keep the fire burning.
Thank you, Daktari. I really appreciate for your time and for the knowledge. I really also wish to request that you will also create some more time for us, because I'm already feeling so much. I want to ask. I know my guys already are having so much to ask. So next time we create a time, we'll still come to you and we want to learn more from you. And thank you so much for that. For now, guys, bye.
Bye, guys.